Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello everyone and welcome to Sensei Podcast. It is my great pleasure to introduce Dr. Basem Elbarouni, who is an associate professor from the University of Manitoba, and he's also the program director for the Interventional Cardiology Fellowship and the CTO program at St. Boniface Hospital. So Basem, thanks again for joining us today, and super excited to hear your story and learn from how your trip has been in CTO interventions.
Yeah, thank you for the invite. Thanks. It's a pleasure to be here, and looking forward to it.
Wonderful. So, Basem, I always ask people to give us a little overview. How did this happen for you? Did you always want to become a complex CTO operator? Did this happen later in your career? How did you get into this area?
Yeah, it's a great question. So, very early on, I knew that I wanted to do interventional cardiology. But before I started my fellowship, I didn't really know what CTO PCI really was. I did my internal medicine and cardiology training in Toronto, and I was lucky to get an interventional fellowship at St. Michael's Hospital. So about 2 or 3 months into my training, Dr. Chris Bueller moved to St. Michael's Hospital as the cath lab director, and he started the CTO program. And during my first year, I could see him do these weird and complex stuff that people were looking at. So I was doing a 2-year program. So I kind of asked him, can I be your fellow for the second year, like learn what you're doing? And he said, absolutely, come join us. So that's really how it started out with me. So I did fellowship training for a second year, focusing on CTO procedures, picked up the techniques. Now, this was back in 2012, 2013. So in Canada, there weren't a lot of centers that were offering or doing CTO procedures. So I kind of was doing the fellowship, but wasn't sure how the job market would turn out. Now, when I was interviewing, I got a job in Winnipeg, where Minvo had already set up a pretty robust CTO program here. So I moved here, joined, and for the first year, I would join him a little bit and then start doing a few cases on my own. But then he moved to Edmonton, and then suddenly I became the CTO operator in Winnipeg and had a full developed program fall into my lap. So I was fortunate that way. So that's kind of how I got into it.
Perfect. So you were inspired, and obviously Chris Bueller has been, phenomenal in many ways, and he has taught many people. So it was a good coincidence in a way that he happened to be at your hospital at the time you're doing your fellowship, so you had the opportunity to work with him at the same time.
Yeah, I was very fortunate that way.
But also, even though you had the opportunity, still, right, getting this done is not easy and has a lot of ups and downs and frustrations and difficulties along the way. So how did you decide that this was something for you and that you were liking to do this going forward?
Yeah, I mean, during the fellowship with Chris Bueller, I actually realized, I'm actually good at this. Like, I can figure out what I'm looking at. I can figure out how the protocol is. So once you feel that you're good at this, you want to develop it further. Plus, there was a need, right? When I moved to Winnipeg and Minvo left, there was a need. There was a huge population that needed to be built up on. So that helped develop that further. And yeah, I just found it very, very, very challenging, very enjoyable. Like your CTO procedure has a lot of steps to it, a lot of challenges on the way. There's lots of algorithms within the algorithms, and it just made the job very interesting.
Perfect. And actually, I had the pleasure of visiting your program, and you've done a phenomenal work getting together, a big group of people and other collaborators, and having everyone come in. And also, we're grateful you're part of the Progress CTO as well. But when it comes to learning, how do you now prepare for your cases? Is there anything different you do now than you did back, a few years back when you were starting the program?
Yeah, it's a very good question. So I think the probably the biggest development that I would say the program had over the last few years is more, or in my practice, is more focus on better case selection. So early on, we had lots of referrals. Lot of times, so we say, okay, this is a CTO PCI. This case looks like it needs a CTO PCI. It could be done. Let's just book them. And I had a few cases where the patient would show up for the procedure, not really knowing what they're getting into. So we're consulting them, explaining them the risks and all that, and that was a change in practice. So we started developing a robust way of selection. Now Mike Love is my colleague here. He moved to Winnipeg from Halifax after I can't remember when exactly, but after Minvo left. So we developed a CTO case rounds where any referral will review them together, look at, is the indication clear, is the procedure relatively doable, what's the risk, what's the complexity, and then we would make a strong effort to make sure we see the patient in clinic so that we know what we're doing and the patient knows what we're getting into, and making sure that the procedure there's a good indication for it. And I think that's probably been the biggest change.
Okay. And then, as you mentioned, you worked initially with Minh Vo, and now you are working with Mike Love. How has that been useful for the learning and for doing the cases and for the overall experience?
Yeah, I'm a strong believer in a two operator system. You're and it's not because for the technical part of it, but more for the mental part. So you're doing a CTO procedure. If you start running into difficulties and trouble, it's very valuable to have a second person there to bounce out ideas. How do we move on? What do we do? Should we do this? Should we, think about different techniques? So usually one of us is the primary, the other the secondary, and usually the primary does the whole procedure, but the secondary person there is more of a mental, support, if you will. And these are very challenging, not just physically, but also mentally challenging procedures. So it's very useful to have someone there.
Perfect. Now, how long does it take you to prepare for a case at this point, given now you have a lot of experience and you've done a lot of cases? Is that shorter than before, longer? How does that play out right now?
Oh, it's starting to get, if anything, it's probably a bit longer because, there's a Dunning-Kruger curve. Once you do more and more, you realize, okay, I don't know everything. I need to plan a bit more. So as I said, we have our CTO rounds. We make notes of what we've seen and what we think the plan is. But on the day before the procedure, I always like to go through the list of the cases and review the angiograms again, refresh my memory, and refresh what needs to be done, and review the notes and all that. And sometimes it looks like it's going to be relatively low cases, but when it's a really complex case, it kind of stresses you overnight. What you're doing the next day, like, what did I get myself into?
Are you sleeping? Are you sleeping over the case? Do you find that you wake up in the morning and you have a solution, or?
Sometimes, but more, it just causes nightmares, I think.
And then, how do you see the learning? Do you feel you're still learning the procedures? Do you think you've reached a pretty good level? How is that playing out?
Oh, there's always learning. So there's the self-learning from every case. This case failed, didn't work out, or cases that worked out because of special techniques. But I find I learn mostly nowadays from seeing what my other colleagues have done in different procedures, what techniques they've used, and trying to think about them and use them when I face similar challenges. So the CTO Plus conference in New York, for example, I try to make sure that I attend every year there. And there's always one or two or three small learning points that I take back from that. There's lots of cases being posted on Twitters with challenges and new techniques, and those are always a very useful resource. For example, it's important that you see something new or a different way to do something, understand when it would be useful and why it would be useful, and save it in your memory bank of techniques, if you will. So, for example, a few years back, the tip-in technique, for example, I saw that done the first time. Like, wow, that's a great technique. If you run into issues with with the revascular externalization wire. So next time I run into that problem, I knew, okay, this is something I could do and use it in that case, and we're able to be successful in finishing the case in something that would have been unsuccessful. Recently, I had a case of an ostial RCA occlusion where we managed to get retrograde, but we had a lot of difficulty getting through. Struggled quite a bit, got through eventually, but then in the CTO Plus course, Dr. Lombardi mentioned doing CART, getting a balloon all the way to the ostium to try and modify that. And when I was doing the procedure, that didn't cross my mind. So next time I run into that same problem, that is something I'm going to try as part of the algorithm. I've put it in my mind that when I get to that type of challenge, when I trained, reverse CART was already taken over. So CART doesn't usually cross our minds very much in the technique. So now I have that saved. So that's probably how I would say the learning is at this point.
Wonderful. And then how do you keep your memory bank, as you say, fresh? You say you go to meetings, you look at the social media, and how any other ways that you keep fresh and keep the interest and techniques active?
Probably the other way the other important way is teaching and training, right? So when you have a fellow that's learning these procedures with you, that's once learned, then you have to teach them. It kind of also refreshes the techniques for yourself, explaining what the steps that are entailed and the safety measures to prevent complications. That's another way to make sure that your memory bank is maintained. Obviously, you have a memory bank of cases where you use different techniques, and those are always good to show to colleagues and trainees as well as a refresher.
So see one, do one, teach one. You are subscribing to this model of learning.
For sure, although I think it's more than one.
Yeah, that's true. That's true. And then when it comes to new equipment and new techniques, how open are you to use new devices? Let's say new microcatheters come in, new re-entry devices. How open are you or not for using these new techniques and devices?
Oh, I mean, it's the best part of the job that you get to play with new toys every so often, right? I mean, there is, and the new equipment. There's some that are just small adjusters, like a new hydrophilic wire, and some that are game disruptors. So whenever I hear something new, it's like, yeah, bring it in. I'd like to try it out a few times. If it looks better or perform better, great. If it didn't feel much of a difference, then it might come down to price difference and all that. But yeah, I think over the years, the more equipment, the better wires, the better microcatheters we've had, the better our the skill grows, the techniques grow, but the equipment definitely helps for sure.
And then when it comes to your stress level, do you get nervous or stressed with these cases? Are you fairly relaxed these days? What is the psychological part of doing these cases?
That's a very good question. So I think, you start the case. If it looks like a relatively low JCTO case, you're relaxed. You know what you're doing. But when you start going down the algorithm into more challenging aspects, obviously the risk of complication goes up, and that's when your stress level really does start going up. So when you're at the level of where you're trying to wire an epicardial, or your contrast or your radiation or contrast level goes up, the risk of complication starts going up. That's when I really do get nervous, and that's where I do think having a second operator is very useful to make sure that it's worth continuing, or if the idea that you're trying works, or if you should stop and back off. But for sure, some of these cases can be very nerve-wracking.
And then how do you maintain your calm, despite obviously the stress and the potential anxiety for that? Is there some specific things you do, or just try to just keep it inside you, or try to take some deep breaths? I mean, what do you do?
I mean, just keep on going. It's in any stressful situation, take a few deep breaths in and keep going. Don't think I would have any major insights. We all deal with stress differently. It's important. I think it's important to try and maintain at least outward calm. Whether it's a CTO PCI or a complex PCI, or even if there's a complication happening, I think it's important in the procedure to try and maintain outward calm. Because if you're the pilot and you give an impression to your team that you're panicking, everyone will start panicking. So you want to keep your nursing team, your assistants, your fellows focused on the procedure and not distracted by the pilot panicking. I think, you know, they give us a certain trust that, okay, Dr. Elbarouni or Dr. Berlakis has done this before. He'll be able to get through this and manage this. So and we'll support him, as opposed to when you're panicking and freaking out, everyone starts panicking and freaking out, and I don't think that's a good situation to be in. So I think that's where my advice there.
And then along the same lines, no matter how good one is, you're going to have failed cases, complications. This is part of the game of CTO interventions. So how do you deal with that? Does it affect you? Does it take you a while to recover from this? How do you deal with the complications and the failures?
So the failures are one thing. If I feel that I've done all I could and the case still failed, I try to learn from it. Why did it fail? Is there anything I could have done differently? Is there other techniques that, if someone else might have been successful, sometimes I'd save the failures and review them with other colleagues across the country. Is there anything they would have done differently? Any advice for next time? The complications, if I'm being honest, the complications are getting probably a bit harder and harder to deal with. Like, as I get older, I do find that they're affecting me more and more than when I first started. I did notice a couple last times, the last bad complications I had. The next day, I'm miserable and think about it for at least a few days. Why am I doing this? Should I stop? Do I know what I'm doing? So I do notice that that's becoming more and more an issue. And I think there are some good talks. I think Sanjog, Dr. Carla, did a few good talks on complications and managing that in CTO Plus a couple of years ago. So I do think that's an issue that's not well addressed in our field. But yeah, I gotta say it is becoming a bit more and more stressful when a complication happens. How to manage that. I do find the courses where complications happen are very useful to learn how to manage the complications and come out with good results, or at least good outcomes. And those are always important to attend and learn from, especially when it's not your complication.
That's excellent. But as you say, this is a tough. I mean, obviously, it's tough for everyone when the patient who comes from elective procedure gets a complication. But again, part of the game. And you're right. Many other people we interviewed. I think Masahisa Yamada, who did the first one, he almost stopped doing CTO interventions after he had a big complication earlier on. So you're right. It does take a toll on us, and finding good ways to deal with this and learn it. That's the best way to go. But now, how about the complications that affect you? For example, radiation. Are you concerned about radiation dose? Do you do anything special to protect yourself and the other team from radiation?
Well, it's the radiation safety is a very important learning point in early fellowship. You have to make sure you know how to reduce your radiation dose, how to maintain a low dose. And in CTO pre-CIs that are very long procedures, it's very easy to lose your eye on how much radiation exposure you've had and the patient had. So yeah, it's always important to reduce your CINEs as much as possible. You don't have to save everything. Use FluoroSave as much as possible. Make sure your shielding is appropriate. Stand away from the patient as much as possible when you're doing the procedure. If you do have a fellow that's learning, that's always a very good way to reduce your radiation exposure. And sometimes you'd have to stop a procedure even if you haven't gone through all the algorithms or techniques, just because the radiation exposure is getting up there. I think it's important as you go along to switch strategies earlier and earlier. So if antegrade wiring is clearly failing, perseverating for a long period of time and trying different wires when it's clearly not going to work is just more radiation. And unlikely to increase your support. So I think moving strategies there is the important thing. We do monitor our radiation exposure. Luckily, we're not too far above the non-CTO operators, so we still get to save ourselves. And newer cath labs are very are way more radiation conservative than the older models for sure.
Perfect. And then when it comes to teaching new fellows, new operators to do these procedures, how do you choose who you're going to teach? Is there a personality characteristic that you look on? Is it their hand skills, on their knowledge? What are the things that make you more excited to teach someone CTO and complex intervention?
I think there's well, first of all, it's something that they have to express interest in, right? Like, I want to learn how to do this. That's always the first step, and if someone's interested, then sure, you need to learn the basics and try and get some exposure. Some trainees are, have seem to be able to pick up the skills quicker than others. And but with time, most seem to get there. As long as you learn the basics and know how to do the procedure, know what your skills are, and know when you need to stop before there's complications, and have a don't have a huge ego, I think is an important thing as well, because we're all learning. And if you're failing to do the procedure, there might be someone else who can do it that you should refer to as your skill and technique is building. But I think first important thing is that someone who is safe, has good basic techniques, is very interested in the procedure, and learns. And yeah, that's pretty much it.
Do you ever say, look, to someone like, look, your hand skills are not good enough. I don't think you're going to be good at this. You should probably drop it, or you just keep on teaching them?
So that's a very good question. So I haven't been in that situation. I've had quite a few fellows come through the general's PCI program, and I think that's probably where the that type of selection might happen, where someone comes out of general cardiology, wants to become an interventional cardiologist, and it's I've had a few trainees start a bit slower than others, but I find that everyone gets there at the end. Now, from the next step to going to the CTO PCI, I think people have insight. I'm actually good at this. I think I'd like to pursue it further. Or, what, I've learned how to be a good interventional cardiologist, a safe one, but I don't think this is for me. So I think people have insight at that point. As a program director, I'm always dreading facing that situation where someone's starting their training, and the first 3 months in, the 6 months in, and they haven't really developed the skill sets, or it's not clear that they're advancing. That part probably would have to have that discussion, but I haven't faced that situation yet. I have seen that happen when I was training, and it was not comfortable for either side. But I think that's where the selection part would happen.
Absolutely. And then I guess that's a great role because you're also the program director, so you see the full spectrum of people who are doing all sorts of interventional procedures. If you were starting now, let's say you were finishing now, and you had the option of structural, now you have the options, for other procedures, structural, peripheral, would you still do CTO, or would you have done, would you choose to do structural, for example, which is the rage right now?
I would do, yeah, no, I think I would still be doing CTOs. I think it's something I find enjoyable and feel passionate about. There are still patients out there that really need the procedure for quality of life, if for any more than anything else. So I think that's the role I'm good at. And yeah, there's lots of structural operators that cover that role, and would be happy to refer to. But no, I think this is my niche, is what I feel good at, and definitely would still do that.
And then, are there some cases over the years that have left a big impression on you, either good or bad ones?
Oh yes, for sure. There are, we've had, some really good successes. I remember one case that had previous bypass surgery. Her RCA was occluded, was clearly CSS class 3 despite being on full medical management. She was in her 70s, so wasn't really that old, and was referred to me. And I look at the diagnostic angiogram, and I really don't see any vessel that I can fix. Like it was just that bad. So I had her in clinic, talked to her, and she was clearly symptomatic. So I actually booked her for a repeat diagnostic angiogram first before offering CTO PCI, where I did dual catheter injection. And based on that, images actually saw a bit of a PDA and a reasonably sized posterolateral branch that I could go after. So I offered her the CTO PCI, but it was really high risk, quoted her a low risk of success, but she was still quite symptomatic. And it was a monster case. It took us about 5 or 6 hours. We went through lots of different algorithms, but we were ultimately successful. And saw her in clinic afterwards, and she was symptom free, enjoying life, gone back to her dancing, and it was clearly the right thing to do for her. So even going through lots of different steps to make sure it's the right thing, it was. We were ultimately successful, and that was quite rewarding. On the bad side, we've had one case that didn't end up well, where she had a prior bypass surgery in the left dominant circulation, and the only patent graft was the Lima to LAD that was retrogradely filling the circumflex, and the circumflex had an osteal 90% lesion. So it's a high-risk procedure. Our only access was to go, and the left main was osteal occluded. We'd had to go retrograde through the left main, which is always not advisable. And despite having MCS for the case, we couldn't get through, and we tried E-cart across the left main, and that ended up, she ended up going into hemodynamic compromise. We couldn't get through the left main. We ended up stenting retrogradely from the LAD into the circumflex with an acute tight bend. Went to the recovery unit, but she didn't recover, and that's been probably one of the cases. Despite it being more than 5 years, every time I remember that, I feel very uncomfortable. And since then, I haven't really tried E-cart, for what it's worth. It's kind of left a negative intonation there.
And I guess that's part of the challenge, right? We're all creatures of habit, and when you have a bad experience with a technique or equipment, then you're probably less likely to use it again down the line. And then maybe there is rationale to this, or maybe it's just psychological, but it does make sense that you tend to favor the things that work and disfavor the things that don't work as much for you.
Yeah.
So, Basem, how do you stay fit for doing, I know you have a big volume of complex and non-complex cases. How do you stay fit to deal with all this?
So it's important to maintain a healthy lifestyle and balance in this job, right? If you want to last long, especially with the long, radiation is one concern, but the orthopedic risk is quite concerned. You're standing for hours wearing leads. So it's important to try and, maintain a good muscular tone. So what's worked for me is a gym called Orange Theory. I'm not sure if you're aware what that is, but it's so I've been an avid user of Orange Theory. So we have one very close to my house, about 5 minutes away. So I try to go in the morning. Actually, they have a class at 5:30 a.m. So at least 2 or 3 times a week, I'd go there 5:30, 6:30, shower, and then head to the hospital to start the day. And that's worked with my schedule. It's a 1-hour class, so you go in, you just do the 1-hour class, and you've got a great workout, and that's been very a good way for me to work out. We live in Winnipeg, so the winter is very cold, so we're more indoors. But during the warmer months, biking to work is also another way that I use to maintain fitness. It takes about 40 minutes to get to the hospital, so that's been quite a good way as well.
So when you arrive, you're ready to go. All adrenaline is running, and you're ready to go.
Yeah.
And then, do you do anything for keeping mental calmness and balance? Do you do anything like meditation, reading some specific things, or any books or things that are movies that you watch?
Yeah, I mean, there's lots of things on TV now to watch. I'm more into audiobooks than books these days. So if you're driving to work, you can listen, etc., and that's quite helpful. Not a high-end reader, more something to relax and enjoy a story. I kind of like Stephen King books quite a bit. In terms of movies, I'd say, my favorite movie is Godfather and Godfather 2. Those movies are just, every time you watch it, there's always some new detail that you've missed the first few times we've gone through it. So yeah. And I also have a PlayStation 5, which play with quite a bit when I have time.
Do you think that this helps with the skills for doing procedures, since there is a manual dexterity part of it, right? That you have to have.
I think so. There's hand-eye coordination. Like when I was growing up, video games were seen as a waste of time, uh, especially with our parents. But nowadays there are kids that are making millions just playing video games, and I do think there's definitely a impact on hand-eye coordination with playing video games. Same as in the cath lab. The hand-eye coordination there works. So yeah, I do think it does improve things there.
And Basem, what are you most proud of? You've done many things, built a great program, you have a wonderful experience there. What are you most proud of in your personal and professional career?
Um, I think I would say probably not proud, but thankful of how things have worked out. I did medical school in Libya and came to Canada on a scholarship, and I'm thankful that things went well in terms of getting the training. I went to University of Toronto for all my training. I did my interventional fellowship there. And in Canada, the interventional cardiology job is quite tight, so there was always a chance the job might not open up. And I came to Winnipeg for the first time for my job interview. And I'm thankful that that worked out, because it's been a great opportunity for me. We talked about how the CTO part developed, but when I came here, despite it being a very large volume center, they weren't offering fellowship training. So I kind of took it on myself to develop that, and that's been a huge success as well. And I think that's very, I would say proud. That's probably the part I'm most proud of. Seeing future generations of our field develop. Like you see someone come into the lab for the first time, don't know what they're doing, and then over the weeks and over the months, they start developing the skills and working independently. I think that's very rewarding. I'm also thankful for my wife and family. The hours we do, the hours of work, the long nights. She's holding the fort at home with the kids and all that. So couldn't do what we're doing without her. So yeah.
Do you show them pictures of your cases to tell them what you've been doing, or you keep the personal and professional separate?
How do I say this without violating HIPAA? Yeah, I've showed them angiograms. My eldest daughter came to for Take Your Kid to Work Day, so she was able to see me do IVUS, a complex CTO, a complex PCI. Wasn't a CTO day. That would be, I think, a bit too overwhelming. But yeah, that was fun. When I'm preparing cases for different rounds or presentations, they see me work on my laptop at home. So they might ask questions. What are you doing? But it's at least it's a coronary angiogram and not an open heart surgery type of pictures.
No, absolutely. And you saw, family makes things, put everything in perspective, and it can be definitely tough on them, these long cases. Do you find yourself that if you have stressed out, you had a long, tiring case at work, that you may be less pleasant at home, or you keep them, you keep yourself in good shape in both directions?
Yeah, I mean, if I'm being honest, that's probably the former. I think if you've had a long day at work and you come home, you're probably not in a good mood, and it probably shows. So I should apologize here when that happens, but we're all human, and hopefully understand that. But yeah, no, I think it's more the former. If I'm being honest, it does take a toll on you, but yeah.
And what excites you for the future? Are there some things that, personal or professionally, that you are very excited for the next few years or 5-10 years?
Well, as I mentioned, I'm originally from Libya, and I think there is some recent efforts over the last 2 years to start networking with operators back home, and I think that's something that I feel excited about. I'm going back home in the summer. Hope to help do a few cases there. Maybe start see if some of the operators there are interested in starting early CTO cases and try and develop there. So trying to improve the care of patient with coronary artery disease back home is something I feel excited about. It's challenging to do with the work schedule in North America and the time difference, but I'm hopeful over the years we can at least have some small contribution there.
Wonderful. Well, Basem, again, you've done a phenomenal work building program, teaching people, doing the research, a big part of progress as well. Do you have any last pieces of advice that you would give to operators who are early on their learning curve and they want to become CTO and complex operators?
It's important to network, see a lot of live cases, see a lot of complications, see, visit operators that are doing CTOs, watch what they're doing and trying to learn the algorithm, and be humble early on. If you're not really sure you can manage potential complications, stop early and refer and learn and build up on that. There will be challenges, but it's ultimately it's quite rewarding for what we do.
Wonderful. Again, Basem, thank you so much. Again, it's been a pleasure working with you over the years. Super excited to continue that. And again, we'll see you at one of the meetings shortly.
Sounds good. Thank you, Anas.
Thank you for listening to the Sensei podcast.